When the very talented chemists that were trying to design Zidesamtinib thought about what to do, there were a few principles. They wanted to make sure they designed a truly next-generation agent beyond the currently approved drugs. It would have substantial activity against ROS1 resistance mutations like the G2032R mutation and other kinase domain mutations, good CNS activity, but in addition also spare the inhibition of TRAC that can be associated with neurologic side effects. In the ARROS-1 dataset, we're certainly seeing for the first time patients pre-treated with repotrectinib and taletrectinib responding to Zidesamtinib. And so that's the first group I'll call out because there are no targeted therapies that are approved for that population. And this is a big win. If we look then at patients who have had one prior TKI like crizotinib or entrectinib, I do think that because the safety profile is more favorable with this drug, and hopefully we'll see a longer median progression-free survival, that instead of using repotrectinib and taletrectinib, oncologists might consider the use of Zidesamtinib should it be approved in these patients. Now ultimately, we really hope to do is in patients with advanced or metastatic disease that have never had a TKI before, if we see that the drug's activity in a larger data set beyond what we presented today continues to hold up with not only good activity, but a longer median progression-free survival than the recently approved agents repotrectinib and taletrectinib, that it will then become our first-line TKI of choice for ROS1 fusion-positive lung cancers. In the ARROS-1 dataset, we only treated patients with advanced or metastatic non-small cell lung cancers. However, as we said in the presentation, there are also other solid tumors that are not lung cancers that harbor ROS1 fusions. So the first thing I hope is that we get a tumor-agnostic indication for Zidesamtinib for any cancer that has a ROS1 fusion. The second thing that I'll say is that we really hope to move these highly active and safe agents into the non-metastatic setting. And so hopefully we would use Zidesamtinib in the neoadjuvant and or adjuvant setting to improve the likelihood of cure in patients with earlier stage disease.